We are now going to move on into diagnosing osteoarthritis. What's next? Would you please welcome Dr. Jolanda Cibere.
Let me just give you a little bit of an outline of what I'm going to talk about. So I'm going to tell you a little bit about osteoarthritis, and you probably know a lot already. And I'm going to tell you about why the use of MRI is so important in osteoarthritis research. And I'm going to discuss some of our research results. My research is focused on looking at risk factors for the progression of osteoarthritis, specifically knee osteoarthritis. And in this talk, I'm going to focus on obesity. And at the end, I'm going to touch a little bit on whether weight loss can slow down osteoarthritis. So osteoarthritis is the most common form of arthritis. It's also called degenerative arthritis or wear and tear arthritis, and it most frequently affects the hands, knees, hips, and spine. And we often use X-rays to diagnose osteoarthritis, especially by the general practitioners, by family doctors. But actually, X-ray is fairly crude. It is unable to show us all the different joint features that are involved in the disease. Am I doing this? So I'm going to show you why that is. Here's an example of an X-ray. On the left, you have a normal knee, a look at the knee from the front, and on the right, you have an osteoarthritic knee. And all you can see on the X-ray is the bones in white. So you have your leg bone and your thigh bone, and in between the bones, you see that black space. That's your joint space. And if that's normally maintained, as it is on the on the left, then you have is what's called a normal X-ray. And as you can see on the other X-ray, you have loss of the joint space here. So that is osteoarthritis. The tissues between here are gone. It's what we call bone on bone. So this is severe stage osteoarthritis. But that's all you see on X-rays, the bones and the space in between. So what's actually in between those bones? Well, here's a diagram that shows you what's in between. So again, on the left, you have a normal knee joint, and on the right is what you see in osteoarthritis. So here again, the bones are in white, but in between here, you see this layer of cartilage that cushions the bones at the end of each bone. It acts as a shock absorber. And this is a key tissue that's involved in the degeneration that occurs in osteoarthritis. So the cartilage becomes thinner, the surface becomes irregular, and eventually the cartilage is gone completely, and that's when you have bone on bone. But it's not the only tissue involved. We also have, we develop bone spurs. The bone underneath the cartilage becomes thicker. Sometimes you even get little cysts or holes in the bone. The capsule becomes thicker, and there's a layer here on the inside of the joint called the synovium. That's producing the lubrication of the joint, so it's very important. But it becomes inflamed, and it causes synovitis when that happens. So an inflamed synovium is what we call synovitis. And what's not shown here is also the meniscus, which also is a shock absorber. So all of these tissues are involved in osteoarthritis, not just what we can see on X-ray. And that's where MRI comes in. So on MRI, we can see the details of all of these tissues. We can see cartilage, we can see bone, meniscus, the ligaments. We can look for joint swelling. We can even see the muscles. So here's an example of an MRI. Again, these are the bones. This is a side view of the knee. And you don't just see the space between the bones. You see this gray layer, so that's your cartilage. You see this black space, that's your meniscus. You can see the muscles. You can see a fusion if there's one there. This is a normal MRI. So MRIs has really revolutionized how we understand osteoarthritis and what we know about it. So what was our research question, and what did we want to study? We wanted to find out what are the risk factors for progression of knee osteoarthritis. We included people in our study that had knee pain and were age 40 to 79. At baseline, we saw 255 subjects in our study, and we invited them all back at 3-year follow-up, and 163 came back and had complete assessments. And we examined them in great detail with questionnaires asking about symptoms, knee examination, and we did an X-ray and an MRI of the more painful knee. And here are some results. So what we found was that osteoarthritis, defined when you look on MRI, is actually very common. We had 38% of people that had X-ray confirmed osteoarthritis in this 255 people in the study. On the other end of the spectrum, the smallest piece of the pie in green showed that 13% had no osteoarthritis. That is, they had completely normal X-ray and completely normal cartilage on MRI. But the biggest piece of the pie is what we called early stage disease. And that was 49% of people in the blue-shaped pie. They had normal X-ray, but abnormal cartilage on MRI. So they already had cartilage damage. This is early disease. This is the group of people that would be missed if you rely on X-ray to make the diagnosis. So MRI can show changes earlier. And that's based on cartilage. But as I've shown you, MRI is more than just, or osteoarthritis is more than just cartilage. What else can we see on MRI? Well, bone bruises is one of the features we never knew about until we started doing MRI in osteoarthritis. What's a bone bruise? Here's an example of an MRI. So here the bones are in black, and the white area is actually the abnormal area. That's your bone bruise. Here's a big, large bone bruise in the leg bone. What do we know about those, and how commonly do they occur? Well, in those people in the study that had X-ray confirmed osteoarthritis, 71% had a bone bruise like that, or multiple bone bruises. In those with the early stage disease, where it only showed up on MRI, 38% had a bone bruise. So 1 in 3 has a bone bruise. But look at this, even people who had completely normal MRI and X-ray, those with no osteoarthritis, 11% had a bone bruise, so 1 in 10. So what does that mean? Well, it means that maybe this is a feature that can occur very early. And we have to study it better at early stage. We do know that bone bruises can come and go, so it may not be a permanent feature, but we also know that bone bruises are linked to pain, and we know that bone bruises are linked to future cartilage damage. So they are an important feature of osteoarthritis. What about joint swelling? We looked on knee examination, and we found that 22% of people in the study had a swollen knee. On MRI, 55% had knee swelling. So again, MRI can show you much more subtle changes than we can detect clinically. And so the knee swelling occurs as a result of the synovitis that I showed you on that diagram, and that means that you actually have low-grade inflammation in the joint. So knee osteoarthritis, it's not an inflammatory arthritis, but low-grade inflammation occurs, and knee swelling is actually relatively common. And interestingly, when we looked at these people with knee swelling, they were 4 times more likely to have bone bruises compared to people without knee swelling. What does that mean? It means that these tissues talk to each other, they communicate with one another. They're linked somehow in the progression of disease. So knee swelling is another important feature of osteoarthritis. So then the question is, well, why do we get knee swelling in osteoarthritis? It's not an inflammatory arthritis. Why do we get synovitis? So that's where we looked at obesity. And we found that in this study, people who were obese at baseline had a 3-fold increased risk of developing new knee swelling, and they had a 3-fold increased risk of developing worsening of knee swelling 3 years later compared to those who were of normal weight at baseline. So obesity is actually the risk factor for knee swelling. There may be other risk factors, but obesity is definitely linked to knee swelling. So what do we know about obesity? Well, it is a known risk factor for the development of osteoarthritis and for the progression of disease, and we've known that for many years with X-ray studies. But what we understand much better now is that this occurs through 2 mechanisms. So there's the mechanical loading of the joint, which makes sense. The more weight you put on, the more pressure you're putting on that joint. But the second mechanism, and I think it's equally important, is that you get low-grade inflammation of the joint, which manifests as knee swelling. And here's another way of showing it. So you have your 2 pathways that lead from obesity to your osteoarthritis. On the right side, you have a mechanical loading That can lead to bone bruises. It can lead to cartilage degeneration, and those two tissues communicate with one another as well. On the left side, you have your low-grade inflammation that is manifested by knee swelling, and I've shown you that knee swelling is linked to bone bruises as well. So you end up having your three key tissues involved in your osteoarthritis. That is the synovium, the bone, and the cartilage, and they all interact with one another until you get to a stage where we can call it osteoarthritis. So if you want to interrupt that, the question is, can we? And what does losing weight impact? Does it impact just the mechanical loading, or does it affect the inflammation? So this brings me to my last question. Can weight loss slow or prevent osteoarthritis? We know that weight loss reduces pain and improves function in knee osteoarthritis, and that's why it's a recommended treatment. And we know that weight loss reduces the risk of new onset disease. But can it reduce some of those changes in the tissues that we see on MRI? There's two studies that recently looked at that, and they showed actually that weight loss did not reduce progression of cartilage damage or bone bruises on MRI, but they studied people with already established osteoarthritis on X-ray, and the studies were fairly short-term. So bottom line is, we don't know whether weight loss has an impact, especially in early stage disease. And that's what we need to study more. So this, I have to finish up. So this is my summary slide. Our understanding of osteoarthritis has improved tremendously with the use of MRI. And we now understand that OA is not equivalent to cartilage damage. It really is a whole joint disease. And we understand that there are complex interactions between the different joint tissues. Obesity increases the risk of knee swelling, and therefore low-grade inflammation threefold in early knee osteoarthritis. And we need further research to evaluate how we can slow the disease. And I think we need to focus on the treatment intervention at early stage. And with that, I would just like to acknowledge the funding sources, ARC, UBC, and funding for the research studies from the Canadian Institutes of Health Research, Canadian Arthritis Network, and the Arthritis Society. Thank you.
Thank you. Are there any questions?
Can you tell us what causes a bone bruise?
Sorry, who asks? Oh, there we go. Okay. Well, a bone bruise can happen for many reasons. Injury will lead to bone bruising too. But it's just a mechanical impact that we think that happens in the bone that leads to the bone repairing itself. And then it shows up like that on the MRI. So it's kind of a repair mechanism that happens. And why it happens in osteoarthritis, I think it has to do with certain loading activities, because it tends to occur more on the side of the joint where the loading occurs. And trauma will do it too.
What's the priority of your MRI schedule?
Sorry.
Every other schedule.
Could we ask that question again for our audience that is joining us virtually, electronically? We need to get the questions by microphone. Sorry.
How easy is it to get an MRI for this particular study or disease versus an MRI for anything else?
If you have osteoarthritis, how easy is it to get an MRI? Very hard. You don't. It's really a good research tool. We use it to understand the disease better, but you don't actually need it necessarily in clinical practice, because some of these things we can detect on physical exam. So you would have a hard time getting an MRI for osteoarthritis unless you have, injury or some other trauma that would prompt the physician to want to look for whether there's damage in the meniscus or ligament tear or something like that.
Hi. In terms of prevention and slowing the progression of OA, I was wondering whether there's research on strengthening the muscles and the other supportive tissues around the knee to bear the weight in addition to actually losing the weight, because one would think that there's kind of two ways of reducing load on joint.
Yeah, muscle strengthening is important. We know that people with weak muscles in the thigh are at increased risk of progression. That just wasn't enough time to talk about all the risk factors. That's definitely a risk factor. So exercise is an important component of managing it, and that leads to stronger muscles. Yeah, it reduces pain and may slow progression of disease. We may hear more about that later.
For the purposes of your research, can you help us understand what the difference is between osteoarthritis and inflammatory arthritis?
The difference is that inflammatory arthritis, there's a few different types of inflammatory arthritis, like rheumatoid arthritis or psoriatic arthritis. The difference is that these are autoimmune diseases. So your body's attacking its own joints in an inflammatory arthritis. In osteoarthritis, that's not, it's not considered to be at that level of inflammation. So you get a lot more damage and severe inflammation in an inflammatory arthritis. And that's why the treatment is so different. And those treatments that we use for inflammatory arthritis would not necessarily work for osteoarthritis.
Hi, Jolanda. Great talk. For exercise, so we're all sitting in your clinic looking at you saying our knees hurt or our knee hurts. We want to exercise. We've heard it's good for us. What do we do? What can we do safely that doesn't exacerbate pain or worsening the disease itself?
Good question. Great questions all around. Walking is a great exercise. Water exercises are very good because you're not loading the joint. I know that's not everybody's cup of tea. Stationary bicycling, I think it should be done with a physiotherapist so that you can be guided in doing the right kinds of exercises at the right level so that you don't exacerbate your pain. I'm told that I have to wrap it up, but we'll be available for questions at the end, I guess.
I've just got 2 online questions, if we could get to them quickly.
Okay.
One was, are bone bruises different from subchondral sclerosis, which has been previously described in the OA literature?
Yes, these are 2 different concepts. So the subchondral sclerosis is thickening of the bone just underneath the cartilage. That's a reaction of the bone to what's happening in the joint. It's kind of, again, a defense mechanism of the joint. Bone bruise is a little bit farther away from that and is a more intense reaction in the bone. So the 2 are definitely different.
And if you have an artificial left hip, can you have an MRI on the right knee?
When you have metal and other hardware in you, you get screened in detail for MRI, and the radiologist will make sure it's safe for you to have it. They may say that it's not, depending on when you had the replacement.